Dr. Sain, can we start?
Uh, Dr. Sayan, We can start now, I think.
Dr. Sayan?
Good evening, all. Welcome to our physics class. And today, again, we have with us, we are very lucky, we have with us Dr. Ganesh, our favorite physics teacher. And you already all, I think, know Dr. Ganesh. He is the chief physicist and head medical physics department, Manipal Hospital, New Delhi. And today's topic is intravascular brachytherapy. So sorry for this delay. So Dr. Sayan Das's mobile got, laptop got hanged. That's why there is a bit delay. So sir, please start the session.
Okay. Thank you very much. And once again, I am glad to meet all of you through this virtual meeting. And today, as already told, we shall be seeing about the 25th chapter in the Khan's book, that is intravascular brachytherapy. Over the next 45 minutes or so, we will be covering uh, various subtopics like target volumes in intravascular brachytherapy, roles of personnel, what are the different type of irradiation techniques, radiation sources that are employed in IVBT, and different radiation delivery systems that have been employed, and those calculation formalisms, calibration of the sources that are used in IVBT, the side effects, the trials that happened initially when IVBT started, whether to use gamma or beta source, and dose rate effects. Also, we will see about edge failure before having a look at the mistakes and mishaps that underline the importance of quality assurance. Now, when this chapter was allotted to me, the first question that came to my mind was, does the chapter have any relevance anymore in the current scenario? And in fact, when I turned the pages, I was in the very first paragraph. In fact, the authors have also raised this question. They state that they debated whether this topic should be included at all in this edition of the book. However, they had finally included, in view of the recent literature, that the findings in the recent literature that the use of the IVBT after the drug-eluting stent can further decrease the likelihood of restenosis. That was the reason that why they had included this topic. At one point of time, in the beginning of 2000s, intravascular brachytherapy was performed in lot many number of patients. Nearly 100,000 patients were treated in 300 centers across US alone in 2002, and up to 2001, 30,000 patients were treated. And at that time, it was the most common application of brachytherapy for few years. But very rarely any application of radiation has been such short-lived as the intravascular brachytherapy. It all started with a big bang, and IVBT became the most common application of brachytherapy. But then within next few years, it all faded down with the development of drug-eluting stents around the same time. Currently, hardly very few centers are practicing intravascular brachytherapy. And I don't have to tell much about restenosis to such an august audience, mostly comprising of PG students and those who have already completed PGs. So I don't have to tell anything about restenosis to you. PTCA, the percutaneous transluminal coronary angioplasty, is a common procedure, as we all know, And a major problem that follows the PTCA is the high incidence of restenosis in these patients. Uh, I hope you all be able to hear me. You are all able to hear me.
Yes, sir.
Yeah, okay. So the restenosis occurs due to two reasons, that is thrombosis or the blood clotting that occurs at the PTCA site, but that has been largely taken care by the drug-eluting stent. However, the new intimal growth of tissues that is prompted by the wound healing process, that also is the reason, or that also leads to restenosis at the same site. Intraluminal radiation, it was found in the early 1990s that intraluminal irradiation lowers the rate of such new intimal formation, reducing the risk of restenosis from about 40% to less than 10% in the patients. What is the target volume that we have to irradiate in intravascular brachytherapy? The target volume is confined to the region of angioplasty. That is, it in lengthwise, it can vary from 2 to 5 centimeter, rarely going up to 6 centimeters in length of the artery. And we have to treat zero point 0.5 to 2 in thickness of the arterial wall. And with the intraluminal diameter of the artery being about 3 to 5 that means that we may have to treat a radial range extending up to 5 from the center of artery. And here in IVBT, inverse square law plays a very dominant role. That is because of the short distances that are involved, that we have to treat only about up to 2 or 3 like that from the source. So inverse square law plays a dominant role, and that helps us to spare the normal vessels and as well as the myocardium from any significant radiation. And because of the same reason, energy is also not that critically important as in the external beam radiation. So energy is not critically important. We will be seeing that why energy is not critically important. WAPM has come out with a couple of publications in the form of task group reports. AAPM recommendations on the depth of dose prescription in intravascular brachytherapy says that for intracoronary applications, the dose shall be prescribed at a distance of 2 millimeter from the center of the sources. It can vary from center to center or practice to practice. But WAPM recommendation states that for intracoronary, it shall be 2 from the center of the source. And for peripheral arteries, it shall be 2 millimeter beyond the average lumen radius. And also WAPM says that the dose distribution has to be evaluated in at least 3 planes perpendicular to the catheter and along the length of the target volume. That shall be determined and evaluated. Average, maximum, and minimum doses should be reported while publishing the reports. Now, this particular diagram tells us the two different approaches. Here in this, the yellow shaded yellow shaded portion is the arterial vessel. And you can see here the source. The source is the central, this straight line. So this is the centered approach. The source is centered along the arterial length. So when this is the source, you can see here this small r, that is the radius of the artery. And this one is the lumen diameter, the reference lumen diameter RLDI, that is the diameter of the lumen. And reference lumen dose point is located at just the lumen level. So this point is the reference lumen dose, and that point is called as the reference lumen dose point. So this is called as the dose point, and the dose at this point is called as the reference lumen dose. And similarly, at a distance of reference depth, which can be either 1 or 2 millimeter, 1 millimeter in case of coronary arteries and 2 millimeter in case of peripheral arteries. That is the depth at which we are going to prescribe the dose in IVBT. So at the distance of reference depth from the lumen dose point, located is the reference depth dose point called as the RDDP, and the dose at that point is called as the reference depth dose point, which is the prescription dose. So we are going to prescribe the dose to this point, which is located at a depth of reference depth, either 1 or 2 mm, depending on which artery that we are going to irradiate. The same picture is here, but only thing is that the source is not centered along the artery length. The source you can see here, it is somewhere very close to the wall and somewhere away from the wall. And in case of such non-centered approach, if the device that we use uses the non-centered approach, then WAPM recommends that you have to also report the maximum reference depth dose uh, and also the minimum reference depth dose and also minimum reference lumen dose. So the minimum dose at this RLDP and minimum dose at RDDP, also maximum dose at these 2 points are to be reported. So obviously when the source is very close to the source wall, then these 2 points will receive maximum dose, and when these 2 points are, when the source is away from the wall, these 2 points will receive the minimal dose. So all maximum and minimal doses are to be reported. This is the center of the vessel lumen. PTL is the uh, planned treatment length. We will see more about this in the subsequent slides. When we look at the stent, you can see here, this is the metallic portion of the stent, but just distal to it and as well as proximal to it, there is some portion of the balloon that will cause injury to the vessel that is being treated with. So that will lead to barotrauma. So a typical stent deployed on its balloon. So the stent is on the balloon, and you can see the tapering proximal and the distal ends contributing to the barotrauma injury just outside the stented region. And this is the barotrauma injury that might actually lead to the restenosis. So the lesion length, applying the ICRU 62 concept, here we define gross tumor, gross target volume, or the gross target length actually. So the lesion length is the GTV. The lesion length where the occlusion is there, the occlusion length is the GTV, or the gross target volume, but it is not equivalent to the target length. So target length is different from the lesion length. The target length, or in other words, the interventional length, equivalent to CTV in ICRU 62, called as the interventional length IL, is defined by the angioplasty procedure. It has to include all positions of the device in the vessel by which the angioplasty was performed. Angioplasty cannot be limited only to the occluded portion. It will actually result in some amount of damage, both distal and as well as proximal. So that injured portion also should be included in the treatment. Such injury may often go beyond the position of the recanalization device, that is the stent, and CTV is often asymmetric. So maybe proximally it is more than the distal or vice versa. Clinical target length should include every part of the injured vessel. So that has to be properly assessed, and every part of the injured vessel must be included in the treated length. And it is very difficult to precisely define. And that is the reason that why we often take 5 to 10 mm on each side of the interventional length as the I mean, as the length that should be treated. The planning target length equivalent to PTV concept, planning target length or PTL, is a safety margin, as we saw earlier. A 5 to 10 mm safety margin is added, that has to be added to the CTV to address the geometrical uncertainties that are patient and device related. So we need to add this safety margin in order to overcome the geometrical uncertainties, and these arise due to patient and as well as the device that we are using for the treatment. So it can occur, or this safety margin will address heart and catheter movements, and also this safety margin will address the inaccuracies in the visual delineation of the ends of the CTV, and the magnitude of the safety margin will depend on the location of the target within the vessel and the delivery system, whether that we are using centered or non-centered, and also the cardiac cycle. And treated volume is the volume irradiated on the basis of the PTV and also the penumbra effect. So this treated volume will depend on isotope, the source design, and the prescription distance. So we will see pictorially. So this is the lesion length where the occlusion is there. And this is the intervention length where the balloon was actually placed and the stent was placed. So this is the interventional length. And then this is the clinical target length. You can see here CTL is definitely greater than the intervention length. So this is the CTL, and we add safety margin to the CTL to get the PTL, and this ASL stands for active source length. So in order to treat this PTL, we have to use a source that is larger or longer than the dimension of the PTL. So the active source length will extend beyond the PTL. And the reference isodose length will be shorter than the source that we have used. So that is the reference isodose level, or just equivalent to the source length. Now, what is the mechanism, or what are the mechanisms of radiation for the prevention of restenosis? Ionizing radiation reduces cell proliferation by damaging the DNA, that we all know. That since we are in this field, we know very well that ionizing radiation reduces the cell proliferation by means of damaging the DNA. And the most pronounced effect in case of IVBT, intravascular brachytherapy, is reported for a dose of around 14 to 20 gray. And here in this case, the target is a mix of different cell population of the adventitia and media. So the cells, macrophage, T lymphocyte, smooth muscle cell, fibroblast, and microfibroblast are inactivated through radiation in different ways. When radiation is given, all these cells are inactivated through damage of the DNA. In the beginning of the process, initially it is the decrease in production of the growth factors and probably maybe extracellular matrix that actually leads to the prevention of restenosis. And then later on, the migration and proliferation of the smooth muscle cells are also reduced. So these are the mechanisms of radiation in preventing the restenosis. So you can see here, this is the initial stenotic artery. Following PTCA, we have injured vessel. There is a small rupture here, elastic recoil, and no brachytherapy. You have neointimal hyperplasia. But following brachytherapy, that neointimal hyperplasia is avoided. Or when a stent is placed here, stenotic artery, PTCA plus stent, the stent, metallic stent is placed. Once again, there is a rupture, and in the healing process, We get neointimal hyperplasia when no brachytherapy is given, but when brachytherapy is given, that restenosis doesn't occur. The American College of Radiology has published practice guidelines for performing coronary vascular brachytherapy, and in this practice guidelines, the roles and responsibilities of the different personnel that are involved in IVBT are clearly explained. Uh, Quite naturally, different specialists have different tasks and responsibilities that are implied on them. The determination of the lesion length, the intervention length, and the reference lumen diameter lies on the cardiologist or the interventional radiologist or the angiologist who is performing the PTCA procedure. So it is this cardiologist or interventional radiologist responsibility to give the dimensions of these values or of these parameters. CTL and PTL are defined by the radiation oncologist in consultation with the physicist who shall be present in the cath lab, and also in consultation with the interventionalist. The treatment planning is done by the physicist once these dimensions are given to the physicist by the interventional radiologist. Immediately the treatment planning, or in other words computing the treatment time, is should be done by the physicist. And basically what the physicist will do is to calculate the reference isodose length, and reference isodose length is the vessel length at the reference depth, which is 1 or 2 mm from the lumen, uh, as we had seen earlier, 1 mm for coronary and 2 mm for peripheral artery. So that is the vessel length at the reference depth enclosed by the 90% isodose line, and it is determined by the physicist and shall be approved by the radiation oncologist before the treatment is administered to the patient. The irradiation techniques that are used in IVBT are both using temporary implants, using sealed sources or liquid filled balloons, or permanent implants in the form of radioactive stents. And in both these approaches, variety of beta and gamma ray sources have been used. So what are the different radiation sources that have been employed in IVBT? The dosimetric requirements out of these sources for a temporary intravascular implant is to deliver a dose of 15 to 20 gray. So whatever source that we are using, we shall be able to deliver a dose of 15 to 20 gray to a 2 to 5 centimeter length. Rarely it can go up to 6 centimeters. So normally 2 to 5 centimeter length of arterial wall at a radial distance of about 2 millimeter from the source center. The source shall be able to minimize the dose to tissues outside the region of angioplasty. To take as little time as possible, the source shall be of that activity and that design such that the treatment time is as little as possible. I remember when I was doing this procedure at All India Institute of Medical Sciences in the beginning of 2000s, I remember for the very first case that we did, when we inserted the iridium 192 into the patient, I calculated the treatment time somewhere close to 30 minutes, around 27 minutes or 29 minutes, I don't remember. But the cardiologist, after about 10 minutes, became highly restless, saying that, oh, I'm not comfortable, I'm not comfortable. And he says that if we stop the treatment at this, will it make any difference? Does it make any difference? So where is 27 minutes and where is 10 minutes of treatment time? And finally, we had to stop the treatment because he said that I cannot wait anything more than 15 minutes. So by 15 minutes, we had to wind up the treatment, even though we know that it would have resulted in very less dose. So the basic requirement is that the source that we use, that should take as little time as possible to deliver the dose of 15 to 20 gray, that is the prescription dose. As regarding the high energy beta sources like strontium 90 or yttrium 90 or phosphorus 32, P32, it will use higher specific activity, and hence it will produce very high dose rate, and they all have longer half lives, and they provide greater radiation safety. But the only problem is that with beta sources, that will be there will be extremely rapid radial dose fall off even within the target region. So within the target region there will be rapid radial dose fall off. But high activity gamma sources like iridium 192, it will produce more uniform dose within the treated region. However, it will require very high activity, and thereby bringing along with it lot many radiation safety related issues. So from the book, you can see here, these are the different type of isotopes, their energies, average energies, half-life, and the activity required. What you have to note down is the vanadium 48 beta source emitting 230 average keV with a half-life of 16 days. It's a permanent implant in the form of radioactive stent, and that requires only an activity of 1 microcurie. Just 1 microcurie is all that is required. So that means that practically there is no radiation safety issue at all with this type of permanent radioactive stent implant. As I told, energy is not that important as regarding the photon sources like iridium 192, iodine 125, and palladium 103. You can see here when we normalize the dose at 1 centimeter, 1 millimeter, when we normalize the dose, then iridium 192, iodine 125, 100, palladium 103, even though their energies may vary quite a lot, but their dose fall off along the radial distance is almost more or less same. So energy is not that important. However, when it comes to beta ray sources, initially they are quite similar to the iridium 192 and other photon sources. However, at longer distances like beyond 2 mm, see, you can see here at 3 mm they start falling off from iridium 192, and at 4 mm and 5 mm they are much lesser than the dose rate produced by iridium 192. What are the different radiation delivery systems that have been used for intravascular brachytherapy? So this is one of the earliest ones that was used, checkmate system developed by a company called Cordis, and it is a manual afterloader device. So iridium 192 seeds were obtained from Best Industries, and that those iridium seeds were used in this device, and they were stored inside a lead pig for storing of the iridium 192 seeds. Source is manually advanced. You can see here that the source is manually advanced by means of this crank. So just like a crank wheel, you have to rotate in order to push the source inside the patient and also retract it back. So source is manually advanced, and either 6 seed assembly or 10 seeds assembly or 14 seeds assembly was used in this device, offering treatment lengths of either 23 mm or 39 mm or 55 mm active source length for these seeds arrangement. Each seed was of 3 millimeter in length, half a mm in diameter, and between the seeds there was a gap of 1 millimeter. Metallic dummy seeds at both ends actually uh, helped in identifying the source length, and the activity per seed was 1.2 gigabecquerel. per seed. And because of the necessity to keep the dwell time or the treatment time to as minimum as possible, the source had to be changed every 4 weeks. We cannot do it like what we do in our HDR brachytherapy. So sometimes we go even up to 2 or 2 half lives. But here it is not possible. The source has to be changed every 4 weeks, and even after that the dwell time will be of the order of 15 to 25 minutes. You remember in the beginning I told that iridium 192 we had to keep it for a period of about 27 minutes. So it is the only FDA approved system with the gamma emitting source, and significant shielding issues made this quite cumbersome technique. It has to be retracted and then pushed from this lead pick, and several other shielding issues made this quite cumbersome technique. I remember at All India Institute we had to keep several mobile lead shields all around the patient in order to reduce the dose to personnel who are standing in the console room of the cath equipment. Because without that, the source dose rate, the radiation exposure rate at the control console will be quite high. So we had to move heavy lead shieldings. We had to fabricate and keep them inside the cath lab. So always with iridium 192, that is the problem. Significant shielding issues made this technique quite cumbersome. Then uh, Novastay BetaCat system, as the name suggests, this used beta source. Once again, this is a manual afterloader device using beta sources of strontium 90, yttrium 90, and this is consisted of a quartz device for housing and hydraulic delivery of the source train. The source train, actually, you can see it here. It is in this window. Actually, you will be able to see the source. At All India Institute, we again had this BetaCat system given to us free of cost. The present ICMR chief, Dr. Balram Bhargav, he had just then returned in 2000 from United States, and he brought with him, means he brought it through the BetaCat company Novastay, free of cost, this device for use in All India Institute. So this used the strontium 90, yttrium 90 source train, and delivery catheter, this delivery catheter to transport the source train had three lumens. The first lumen to push the guide wire, and the second lumen to push the source train forward, that is from the equipment through the catheter to the patient, that is to the tip of the catheter. So here is the tip. So when you push this syringe here, this syringe is permanently attached to this equipment. So when you push the this syringe, then due to hydraulic pressure, the source train will move from the source housing to the tip of the catheter. And then so see here, this particular, this is the lever. When pushed to this here, then it will send the source out, and when this lever is pulled down, then it will return the source. So when you are injecting the liquid through the syringe, if the lever is here pointing to this direction, then the source will go out. And when the lever is pointing here downward, then the same action of pushing the liquid will actually push the source hydraulically back from the tip back to the equipment. So that is how the source is moved manually from the equipment to the tip of the catheter and back from the tip of the catheter into the device. and the dwell time here is just about 3 to 4 minutes. Remember, beta sources have got higher specific activity, and because of that, the dose rate is very high, and the treatment time obviously is very less. So beta cat system, you can see here, this is the lever. When it is pointing in this direction, it is sending, and when it is pointing here, it is returning. So you can see the physicist or the radiation oncologist pressing the syringe, pushing the syringe, and injecting or pushing the source strain through the catheter into the patient. And the source is made out of a jacketed radiation source train called JRST. JRST series of sealed miniaturized beta sources in a coil or in a jacket of train designed to provide even dose distribution. So this type of arrangement allows quick and easy position, and also we can verify whether the source has been positioned correctly or not. And it is designed to maintain flexibility to navigate even very sharp turns while keeping all the sources together. And multiple fixed length uh, is available were available for optimal lesion coverage. That is, for 30 separate device, for 40 separate device, and for 60 another device. If you can see here, just one second. So you can see here on the side it is written 60 So this device is meant for treating 60 length. If the treatment length is less, then you have to have another device. So there are three designs: 30 40 60 and either 12 or 16 or 24 seeds are used in these devices, and each seed is of 2.5 in length, and each seed has an activity of 0.13 gigabecquerel in each seed. And the catheter is very thin, 3.5 French delivery catheter, smallest delivery catheter available, and easily it can fit into a 6 French guide catheter and allows access to even distal anatomy. Single catheter can accommodate any source strain length, and 1 centimeter distal rapid exchange type catheter is used here. So you can see here, this is the stenosis part. PTCA balloon is placed, and the source train you can see here, and then following the procedure, you can see the artery cleaned up. Another system, Galileo system by Guidant Corporation, once again using beta emitting, but this time source is different, P32 of length 20 millimeter of active source length, maximum 10 gigabecquerel used. The system had the ability to deliver the source electronically through a computerized stepping delivery afterloaded. So this is not manual, but this is done using a computerized system. And the most important difference is that it had a centering catheter spiral balloon. You can see here, this is the spiral balloon. So when the balloon is inflated, automatically it will center the source along the center of the artery that is being treated. So this special spiral balloon design allowed us the centering of the catheter with the treatment length of either 27 or 54 millimeter. Dwell time, once again, is very short with this beta source of only 2 to 5 minutes. And it had an inactive dummy in order to check, just like in brachytherapy that we use HDR. We initially send the dummy to check whether there are any kinks or not. So here also there is a dummy that will actually initially run and to check whether any kinks are there, and whether the source can negotiate sharp bends. It will be checked by this dummy run. And beta emitting liquid filled balloons were also used, balloon dilation catheter with beta emitting radioactive liquid. So you have to dilate the catheter with beta emitting radioactive liquid, P32, yttrium 90, and rhenium 188 was, these were the sources that were used. Rhenium 188 is preferable. That is because of reduced dose to other organs like colon and the thyroid due to its rapid renal elimination in case of balloon rupture. In case the balloon is ruptured, it will be quickly released from the body. But the major disadvantage with this type of balloon filled with beta emitting radioactive liquid is that higher ratio of surface to adventitia dose compared to the gamma system. That is, at the surface, what is the dose, and at the adventitia, what is the dose? The ratio of the surface to adventitia dose is very high with this type of beta sources. I told you, in the target region, beta sources produce non-uniformity, whereas gamma systems produce uniform doses. Possibility of balloon rupture is there, and the risk of radioactive liquids spillage within the patient is always there. Permanent radioactive stents have also been used. Beta emitting isotopes like P32, yttrium 90, and vanadium 48 are suitable for impregnation into the stent. So how it is manufactured is that once the stent is formed by this material, they are activated in a cyclotron or by ion implantation. Many advantages are there: stenting and irradiation in one procedure. In the previous procedure, you have to do first stenting followed by irradiation by inserting the radioactive sources. But here, since the stent itself has got the radioactive source, stenting and irradiation is done in one procedure, and proximity of the source with the vessel walls. So here, because it is in the stent, it is very, very close to the source, the arterial wall. Not unlike in the previous other applications, the source is at the center of the artery, but here the source is right on the uh, arterial wall. And it is the safest procedure because activity is just 1 microcurie. So practically there is no importance of radiation safety at all. The only drawback, which is a very important drawback, is that dosimetry is much more complicated because of the design of the source. Dose calculation formalisms, if you look at the chapter in the Khan's book, actually this is the longest part in the chapter, how the dose is calculated. But I am not going to go into the details of the dose calculation formalisms. That is meant for more for the physicists. But all you have to know is that even though these dose calculation formalisms may appear daunting, very complicated, but in reality, if you know the principle, actually they are very easy to implement, for the simple reason they are just formalisms, means just only the formula are used. But in external beam therapy, the formula are not used, rather uh, uh, algorithms are used. So algorithms are much more complicated than formalisms. Formalisms, it's very simple. TG43 and TG149 based formalisms are used. TG60 is discontinued. Monte Carlo techniques have also been employed for calculating the dose, and dosimetry for radioactive stents are complicated, as we had seen in the previous slide. That's because of the gridded structure. And for measuring the dose, radiochromic films have been successfully employed for measuring the dose distribution near sources. Dose calculation is very difficult near the sources because of the very high dose gradient, but however, they can be successfully measured with the help of the radiochromic films. Regarding calibration, when it is catheter based gamma ray sources, we have to measure the strength of the gamma ray sources by measuring what is called as the air karma strength, SK, at a certain distance called as the reference distance. So at that reference distance, we have to measure the air karma strength. That is how gamma ray source is calibrated. And also, in addition to this air karma strength, you have to know what is the dose rate that it will produce in water at 2 millimeter from the center of the source. That also must be specified by the vendor or by the physics team. Catheter-based beta ray sources, once again, dose rate in water at 2 millimeter from the source must be specified. And for this, extrapolation chamber can be used for measuring the dose rate in water at 2 millimeter. Radioactive stents, they actually pose a lot of challenges, and only a Monte Carlo dose calculation can help us in calculating the source strength of the radioactive stents. Side effects of brachytherapy, intravascular brachytherapy: late stent thrombosis can happen, and sudden thrombotic occlusion within the stent at 2 to 6 months can happen. It occurs after stenting and brachytherapy. Frequency is about 15% in the 15% of the patients. Rarely seen if no stent is placed. The underlying mechanism is the delayed re-endothelialization to cover the stent stretch. And also, IVBT can lead to aneurysm formation. There have been several trials. The very first trial was started in Venezuela in year 1992, and the first paper came in 1997. This was the first paper, long-term angiographic and clinical outcome after percutaneous transluminal coronary angioplasty and intracoronary radiation therapy in humans, 1997, and this trial started, I think, in 1992. Uh, and the dose was 20 to 25 gray, but the actual dose was 19 to 92 gray. Later on, it was computed. Scripps 1 trial delivered a dose of less than 8 gray to the furthest external elastic lumina, delivering the minimal dose in all these trials. Wrist trial delivered a dose of 15 gray to 2 mm radius for lumen less than diameter 4 mm and 2.4 mm for larger diameter. 15 gray to either 2 mm radius or 2.4 mm radius. Gamma 1 trial used checkmate device. Wrist plus trial also was there. Similarly, START trial using beta cat system. These are the doses for different vessel diameters. START 40-20 trial for using the source train length 40 mm instead of 30 mm. Inhibit trial used a Galileo system. Catheter was centered and 20 gray was prescribed at 1 mm from its surface. Gamma 1 trial, wrist plus trial, Beget trial, beta versus gamma. That is why it is called Beget trial. Gamma or beta, each has got its own plus points and negative points. Gamma emitting sources improved depth dose gradient, and there is no attenuation whatsoever produced by the calcium inside the vessel lumens or by the metallic stents. So the metallic stents are not going to produce any significant dose attenuation of the gamma rays. And radiation safety is the biggest problem with these gamma ray sources: exposure to lab staff, lead shielding, and longer treatment times. Beta emitting, on the other hand, they use longer half-life isotopes. Higher specific activity result in higher dose rates, which means that it's easy radiation protection, better radiation protection, because energy, it is very easy to shield against the beta ray sources. Shorter treatment times, so that gives a lot of comfort to the interventional radiologist and the cardiologist. And it can be but the problem is that it can be attenuated by calcium and metallic stents, because they are beta rays. Calcium and as well as metallic stents will attenuate the rays, and it will change the dose that is being given to the patient. And the dosimetry is complex due to the beta rays, and initial results of the Beget study were negative. Means the Beget study, beta versus gamma, did not show any positive uh, results in favor of beta ray sources. Dose rate effects, we know biological consequences depend not only on the dose but also on the dose rate, the rate at which the dose is delivered to the patient. Dose rate is important for three reasons. Radiation is applied very close to the source where the dose gradient is high. Different trials, as we had just now seen, tried different source types, different source strengths, and different type of source designs, which means that dose rates in these trials varied between 50 centigrade per minute to 500 centigrade per minute, a huge difference. Different doses at different radial distances. So you cannot straight away compare these trials because they all delivered different doses at different radial distances. Different source types and designs have different dose gradient profiles also. The way the dose falls off from one point to another point, the dose gradient were different with the different sources. Edge failure, or in other words, geographic miss, when restenosis occurs after IVBT. After IVBT, if the restenosis occurs, re-narrowing was found at the treatment edges in about one third to one half of the patients in whom restenosis occurred after IVBT. Most likely cause inadequate radiation dose to the injured lesion margins. That can happen due to geographic miss, that is misalignment of the source within the injured segment of the vessel. The source was not properly aligned within the injured segment of the vessel, or the balloon catheters can slip forward or backward, resulting in unintended injury to the lesion margins. So any unintended injury to the lesion margins can further produce restenosis. Barotrauma contribute to the arterial wall injury. Longitudinal seed displacement again can be the cause, uh, resulting in geographic miss. Uncertainty in the target localization, that's a very crucial part. So the interventional radiologist or the cardiologist has to clearly tell you all the dimensions and also localize the target placement, dose fall off, and the penumbra effect of the particular isotope. Mistakes, several mistakes and mishaps have been reported with all these uh, uh, delivery systems. Like in Novaste BetaCath, malfunctions have led to several events, resulting in dose at wrong site, and the source was found to be leaking in some instances. Guidant Galileo, oh, just once again, my battery is down. I'll just take a minute. I have to put it on power. My battery is running very low.
Okay, sir.
Sorry about that. I had to switch on the power supply. Guidant Galileo using the P32 wire, new catheter required use of different catheter, and resulting in wrong site being treated. So different catheter lengths resulted in wrong site being treated. Cordis checkmate using iridium 192 seeds, wrong arterial dimensions used in the intravascular ultrasound based dosimetry. Decay of source was calculated wrongly using the P32 half-life. Actually, the source used was iridium 192, but someone calculated using the P32 half-life. Angerod iridium 192, another device, source was stuck in the delivery catheter when the drive cable jammed. Radiance RDX balloon tore and released 15 millicurie of P32 liquid in the bloodstream and irradiating the entire body. Liquid rhenium-188 balloon tore and released 3 to 4 millicurie of radioactive liquid in the bloodstream. So a lot of quality assurance tests are to be conducted. I will not go through all these each and every line, but they are very simple. You can follow it up, document radiation. You have to document the radiation source properties, develop protocols for receipt of sources, acceptance testing and commissioning. All these things I'm going to share these presentation with all of you, so you can go through them and you can see. So quality assurance, just because to prevent these mishaps that we had seen earlier, lot of quality assurance, strict quality assurance tests are to be done and documented. Everything should be documented, and procedures, policies and procedures should be developed. This would be my last slide. This is a must read for all of you to know more. The chapter as such in the Khan's book is very short one. In order to know more about the intravascular brachytherapy, I would recommend all of you to just read this link, which actually deals with the subject in an elaborate manner. I think with that, I will end, and I will be now open for any questions.
Thank you, sir, for this excellent discussion and adding your personal experience as well. So that was really useful. I now request the participants to write down their questions in the chat box.
Chat.
I think there are a few.
Is there any question anyone wants to ask? They can write in the chat box.
So I think again a difficult topic. So that's why.
Not only difficult topic, a topic that has probably lost its relevance. I don't know whether anybody is practicing at all, even though I told that there are some centers that are doing. I'm not sure that whether really any centers in US are doing at this point of time.
Uh, yes, we do agree. Again, so
And
it's
even in India, I don't know whether any centers really practiced it in an extensive way. Even at All India Institute of Medical Sciences, even though we had iridium-192 seats that we bought directly from Best Industries, and also the beta cath system, we never put into what I can say, very intensive use. Like, we didn't treat very many patients. We treated less than 10 patients at the most. I'm not sure exactly. I don't remember, because this was in year something like 2002, 2003, like that.
okay. Uh, we're still waiting for the questions.
I think I can ask one question, whether anybody knows any center in United States or in any other country doing this procedure now? Anybody knows? When this topic was given to me, that was the first thing that came to my mind, that anybody would be practicing.
I don't think so, sir.
Yeah, yeah.
So I don't think there are any questions for you for the time being.
Yeah,
But
yeah.
we are going to have, sir, for more sessions in the future. And so I think sir will be discussing about total body irradiation as well. So I
Yes.
request the participants that please go through the chapter once more, and you can once again go back and see the video that will be uploaded on YouTube. If you have any more questions, then we can still ask sir for further clarifications. So thank you, sir, once again.
Okay. Okay. Thank you.
Uh, so thanks to the participants as well. So that's it for today.
Okay. Right. Thank you.
Goodbye and good night.
Good night.
Thank you, sir.